So now let's continue with the beta blockers. So the beta blockers are acebutolol, atenolol, betaxolol, carvedilol, esmolol, nebutalol, metoprolol, nadolol, nebivolol, pindolol, propranolol, and timolol. So basically, these are all beta blockers. The important one are the important one of them are labetalol, esmolol, metoprolol. Yes, these are the and propranolol definitely. So these are the important one, and you may remember all of these if you want to. Then the application is angina pectoris, decrease heart rate and contractility, resulting in decreased oxygen consumption. In myocardial infarction, beta blockers like metoprolol, carvedilol, and bisoprolol they will decrease the mortality. Supraventricular tachycardia. In SVT, we give metoprolol and esmolol. So they decrease the AV conduction velocity and class 2 antiarrhythmics. Hypertension, decrease the cardiac output, decreased renin secretion due to beta 1 blocker, beta 1 receptor blockade on the juxtaglomerular repetitive cells. Heart failure, we give beta blockers because they decrease the mortality in chronic heart failure. And glaucoma, uh, we give timolol, they decrease the secretion of aqueous humor. Toxicity, the toxicity of the beta blockers is that they can cause impotence, cardiovascular adverse effects like bradycardia, AV block, heart failure, CNS adverse effects like seizures, sedation, sleep alterations, dyslipidemias like metoprolol, and asthma, COPD exacerbation. Avoid in cocaine users due to the risk of unopposed alpha adrenergic receptor agonist activity, despite theoretical concerns of masking hypoglycemia in diabetics. Benefits likely outweigh the risk and they are not contraindicated. Selectivity, beta 1 selective antagonist, beta 1 more than beta 2, acebutolol, partial agonist, atenolol, betaxolol, esmolol, and metoprolol. So selective agonists mostly go from A to M. Beta 1 with first half of alphabet. So like from A to M, they are beta 1 selective antagonists. Yeah. So all the drugs with the lol suffix are antagonists. Okay. So yeah, non-selective antagonist beta 1 is equal to beta 2 are nadolol, pindolol, partial agonist, propranolol, and timolol. Non-selective antagonists mostly go from N to Z, beta 2 with second half of alphabet. Non-selective alpha and beta antagonists carvedilol and labetalol. Non-selective alpha and beta antagonists have modified suffixes instead of olol. Okay. Um, then the next thing is nebivolol combines cardiac selective beta 1 adrenergic blockade with stimulation of beta 3 receptors, which activate the nitric oxide synthase in the vasculature. The Uworld point about the beta blockers lower the blood pressure via two mechanisms, reducing the myocardial contractility and heart rate, decreasing renin release by the kidney. After the initial stabilization, beta blockers like carvedilol and metoprolol should be started in all heart failure patients with left ventricular systolic dysfunction to improve the survival. Beta blockade decreases the cardiac work by slowing the ventricular rate. It also reduces the peripheral resistance after load by decreasing the circulating level of vasoconstricting hormones, for example, norepinephrine, renin, and endothelin. Beta blockers should not be initiated in the patient with unstable heart failure and should be introduced slowly to avoid worsening of the patient's condition by further impairing the cardiac output. Hydralazine. Hydralazine is it acts more on the arterioles and veins, but I think it acts on both tissues, but it is more dilated to arterioles than veins. So hydralazine increases the cyclic GMP that causes smooth muscle relaxation. It vasodilates arterioles more than the veins, and afterload reduction is the outcome. The clinical use is severe hypertension, particularly acute heart failure with organic nitrate. It is safe to use during pregnancy. Frequently co-administered with a beta blocker to prevent the reflex tachycardia. Adverse effects: compensatory tachycardia contraindicated in angina, coronary artery disease, fluid retention, headache, angina, SLE-like syndrome. The usual point is that although direct arteriolar vasodilators like hydralazine and minoxidil are effective in lowering the blood pressure, they can often cause reflex tachycardia and edema. Due to these bothersome side effects, these agents are rarely used first line and are usually reserved for the patient with severely uncontrolled hypertension who are resistant to other drugs. To help mediate these side effects, these agents are often given in combination with sympatholytics and diuretics. Hypertensive emergency. Hypertensive emergency treated with clofazimine, phenoldiazepam, labetalol, nicardipine, and or nitroprusside. Nitroprusside, short acting, they increase the cyclic GMP via direct release of nitric oxide, can cause cyanide toxicity, that is release cyanide. Phenoldopamin, dopamine D1 receptor agonist, coronary, peripheral, renal, and splanchnic vasodilation. They decrease the blood pressure and increase natriuresis. Also used post-operatively as an antihypertensive, they can cause hypotension and tachycardia. The Uworld point is that treatment of post-operative hypertension is esmolol, short-acting and easily reversible. Treatment of hypertension with renal insufficiency is phenoldopamin, the only available IV agent that improves the renal perfusion while it lowers the blood pressure. The Kaplan point is that nitroprusside decreases the total peripheral resistance in the arteries and veins, so used in hypertensive emergencies. The drug of choice is used IV. Side effects are cyanide poisoning, which is treated by nitrites. They produce methemoglobin, which binds the cyanide, and cyanomethemoglobin. Thiosulfate converts the cyanomethemoglobin to methemoglobin. Nitrates. Nitroglycerin, isosorbide dinitrate, and isosorbide mononitrate. Mechanism. They vasodilate by increasing the nitric oxide in the vascular smooth muscle and increase in cyclic GMP and smooth muscle relaxation. The nitrates dilate veins more than the arteries, and thus they decrease the preload, because if the veins are dilated, the blood will be pooled inside the veins and that will not come to the heart. The clinical uses angina, acute coronary syndrome, and pulmonary edema. Adverse effects: reflex tachycardia treated with beta blockers, hypotension, flushing, headache, Monday disease in the industrial exposure, development of tolerance for the vasodilating action during the work week, and loss of the tolerance over the weekend leads to tachycardia, dizziness, headache upon re-exposure, contraindicated in the right ventricular infarction. What are the mechanism of action of nitrates? So basically, the pupillary endothelial cells, arginine is converted into nitric oxide by the endothelial nitric oxide synthase. This nitric oxide will diffuse into the smooth muscle which are present below that. The nitric oxide stimulate the guanylate cyclase to convert the GTP into cyclic GMP. This cyclic GMP will act on the myosin light chain to cause relaxation. This cyclic GMP can be degraded by the phosphodiesterase into GMP, and this thing is inhibited by the sildenafil. The calcium enters the cytoplasm and binds and causes the phosphorylation of myosin light chain, and that is responsible for contraction. Okay. Got it. Then the next thing is over here, mechanism of action of anti-anginal therapy. So they increase the coronary vasodilation, non-dihydropyridine, calcium channel blockers, dihydropyridines, and the nitrates. Venodilation is caused by nitrates, and they decrease the preload. Decrease in heart rate is done by the beta blockers, non-dihydropyridines like verapamil and diltiazem. And arterial dilation, they decrease the afterload, that is dihydropyridines, amlodipine, and nifedipine. The Uworld point is that nitrates are the venodilators, and they decrease the preload, decrease the left ventricular volume during the diastole, which is the main effect in the stable angina. NBME point is that nitrates are vasodilators in low dose, but in high dose they cause arteriolodilation and decrease afterload, but it also decreases the coronary flow. Another Uworld point, which nitrate has the highest bioavailability if given oral, it is isosorbide mononitrate. Another Uworld point is that nitrate must be avoided in the patient with a hypertrophic cardiomyopathy due to increased outflow tract obstruction, right ventricular infarction due to the reduction in preload impairing the cardiac output. Those on the phosphodiesterase inhibitors, synergism increases the risk of severe hypotension. Then a Kaplan point is that tachyphylaxis of nitrates, receptor downregulation, people who use the patch should remove it at night to prevent tachyphylaxis due to depleted glutathione source. So basically, it is an adaptability to the whole drug thing. Like if you are taking the drug, the receptors will get downregulated, and then the same dose of drug will not act. That is a phenomenon of tachyphylaxis. So the people who are using the patch or the nitrates should remove it at night so that they don't develop tolerance to that particular drug dosage. Side effects of common antihypertensive medication. First, we will talk about thiazide diuretics. Side effects are acute kidney injury. Electrolyte disturbance include hyponatremia and hypokalemia, hyperuricemia and acute gout, elevated glucose and cholesterol levels. ACE inhibitors, the side effects are cough, angioedema and hyperkalemia. The calcium channel blockers amlodipine and nifedipine, they cause peripheral edema, dizziness or lightheadedness. Beta blockers, bronchospasm, bradycardia, fatigue and sexual dysfunction. Anti-anginal therapy. So anti-anginal therapy, the goal is reduction of myocardial oxygen consumption, MVO2, by decreasing one or more of the determinants of MVO2 end diastolic volume, blood pressure, heart rate, and contractility. So with the nitrates, the end diastolic volume will decrease because they decrease the preload. The blood pressure will decrease. Contractility, there will be no effect on contractility. Heart rate will be increased. There is a reflex response. Ejection time will be decreased, and MVO2 will also be decreased. With the beta blockers, end diastolic volume will not be affected or will be increased. The blood pressure will be decreased. Contractility will be decreased because beta 1 receptors are present in the heart which stimulate the contractility, and if you're giving beta blockers, so that effect will be hindered or obstructed. Heart rate will decrease. Ejection time will increase. Yeah, it will take longer for the blood to leave the heart. And MVO2 is the, what is MVO2? MVO2 is the oxygen consumption by the myocardial cells, like it is written over here. Yeah, so that will decrease. So this is the end goal. We want to decrease the oxygen consumption by the cells to prevent the angina. Angina is basically the supply demand mismatch, right? So if we decrease the consumption of oxygen by the cells, so this is what is happening. Then end diastolic volume, nitrates and beta blockers. So end diastolic volume, there is no factor that decreases, that is decreased. Blood pressure is decreased. There is little or on contractility, there is little or no effect. Heart rate, no effect or it is decreased. Ejection time, it has little or no effect, and MVO2 is decreased. Verapamil is similar to beta blockers in the effect. Pindolol and acebutolol are partial beta agonists that should be used with caution in angina. Then we have ranolazine. The mechanism of the ranolazine is that it inhibits the late sodium current, reduces the calcium overload which cause high wall tension, and reduces the wall tension and oxygen demand. The clinical use is angina refractory to other medical therapies. Adverse effects include constipation, dizziness, and headache. QT prolongation, blockade of potassium channels can occur in the ranolazine. So this is phase 0 and late sodium influx is happening like that, sodium and sodium calcium. Then we have milrinone, selective phosphodiesterase 3 inhibitor. In cardiomyocytes, increased cyclic AMP accumulation lead to increased calcium influx and increased inotropy and chronotropy. In vascular smooth muscles, increased cyclic AMP accumulation will lead to inhibition of the myosin light chain kinase activity and general vasodilation. Clinical use, short-term use in acute decompensated heart failure. Adverse effects include arrhythmias and hypotension. So with milrinone pharmacotherapy, you must remember that milrinone basically is a phosphodiesterase 3 inhibitor and increases the cyclic AMP accumulation. We have seen it because the phosphodiesterase is going to cause the conversion of cyclic AMP into AMP, and thus the relaxation effect created by the cyclic AMP or cyclic GMP that is gone. So we have to protect that, and to do that, milrinone inhibits the phosphodiesterase 3 enzyme, and thus the relaxation is prolonged. The adverse effects can be arrhythmias or hypotension. Okay, so this is a beta receptor. Beta receptor stimulates adenylate cyclase to convert the ATP into cyclic AMP. The cyclic AMP can be broken down into AMP by the phosphodiesterase 3, and this effect is inhibited by the milrinone. Now, cyclic AMP, when it acts on the cardiac muscles, it will cause calcium channel activation. Cytosolic calcium will lead to actin myosin troponin interaction, and there will be positive inotropy. Okay. Cyclic AMP causes contractility of the muscles and vasodilation of the arterioles. So CAMP dependent protein kinase will lead to augmented calcium uptake by the sarcoplasmic reticulum. So this is causing the calcium to be pushed into the sarcoplasmic reticulum and vasodilation. So you must remember the CAMP on one hand is causing vasodilation in the vessels and also is positive inotropic agent for the cardiac myocytes. Then we have Kaplan point, that is potassium channel openers, minoxidil and diazoxide. These open the potassium channels, potassium will leave the cells, and cells will, when the positive charge will leave the cell will get what? Cell will be hyperpolarized, I guess. So increased potassium efflux will lead to hyperpolarization of smooth muscle, and that will lead to arteriolodilators. That will cause arteriolodilation. Use is hypertensive emergency. Diazoxide. In hypertensive emergency, we give the diazoxide that decreases the insulin release. So used also in the treatment of insulinoma. Severe hypertension, minoxidil, hypertrichosis is the side effect. So we can also use minoxidil in baldness. Energy for myocardium is coming from three sources. First one is glycolysis. Then glucose oxidation, less oxygen consumption, and produce more ATP but require more oxygen. Fatty acid oxidation inhibitors, newer drugs for treatment of angina aiming to shift from fatty acid oxidation to glucose oxidation. Then let's talk about lipid lowering drugs. Then after that, what else will be left? Okay, then the what to go right. So lipid lowering drugs, first one are HMG CoA inhibitors, which are also called as statin drugs, rovastatin and pravastatin. So they decrease the LDL, increase the HDL to some extent, and decrease the triglycerides. Mechanism of action is that they inhibit the conversion of HMG CoA to mevalonate, a cholesterol precursor, and decrease the mortality in coronary artery disease patients. Adverse effects include hepatotoxicity, that is increased LFTs, myopathy, especially when used with fibrates or niacin. Bile acid resins, they are cholestyramine, cholestyramine, and cholecalciferol. They decrease the LDL, slightly increase the HDL, and slightly increase the triglycerides. They prevent the intestinal reabsorption of bile acids. Liver must use cholesterol to make more. But in an attempt, liver also produces more cholesterol, so they are good but not very good. They can cause GI upset, decrease absorption of other drugs and fat soluble vitamins. Then we have ezetimibe. Ezetimibe prevents the cholesterol absorption. The bile acid resins were inhibiting the bile acid accumulation, bile acid reabsorption, while the ezetimibe is inhibiting the cholesterol absorption at a small intestine brush border. So it decreases the LDL only, and rare increase in LFTs and diarrhea can be a side effect. Then fibrates, gemfibrozil, bezafibrate, and fenofibrate. They decrease the LDL, increase the HDL, and the main effect is to decrease the triglycerides. Okay, so the mechanism is to upregulate the LPL and increase triglyceride clearance, activate the PPAR alpha to reduce the HDL synthesis. Myopathy increase the risk with statins and cholesterol gallstones. Niacin, vitamin B3, they decrease the LDL, increase the HDL, and decrease the triglycerides. Inhibit lipolysis, hormone sensitive lipase in adipose tissue, and reduce the hepatic VLDL synthesis. Red flushed face, which is decreased by NSAID or long-term use, hyperglycemia and hyperuricemia. So here you can see that in the blood. These are basically the mechanism of action of the drugs. So the chylomicrons, when acted upon by the lipoprotein lipase, they release the free fatty acids. Then we have HDL pool. Okay, and chylomicrons are also remnants are also taken up by the liver by the ApoE receptors. They release the triglycerides and cholesterol. The triglycerides, the triglycerides are taken up by the VLDL and also the cholesterol, and then the VLDL enter the circulation. Lipoprotein lipase breaks down the free fatty acid from that and store them in the adipose tissue. And after releasing the free fatty acids, the VLDL becomes LDL. LDL is then again taken up by the liver, and cholesterol is returned to the liver. HDL is also taken up by the livers by the HDL receptors, and again cholesterol is back. So then acetyl CoA is converted to HMG CoA, then HMG CoA reductase convert the HMG CoA into mevalonate, and then that is also converted to cholesterol. So all of these are the sources of cholesterol. Now mevalonate synthesis is inhibited by the statins like lovastatin, pravastatin, simvastatin, atorvastatin, and rosuvastatin. Okay, LPL upregulation, so that more and more free fatty acids can be taken up. That is done by the fibrates, gemfibrozil, bezafibrate, and fenofibrate. Adipose lipolysis is done by the niacin. Then coming here, we can see that in the intestinal human, this is cholesterol absorption. So cholesterol absorption is inhibited by the ezetimibe. Bile acid absorption is inhibited by the bile acid resins like cholestyramine, cholestyramine, and cholecalciferol. So basically, from the gut, they are converted into cholesterol free fatties and biles are taken up by the chylomicrons by the lymphatics reach the circulation, and then the whole cycle is as we discussed before. Then we have the next thing, that is anti-hyperlipidemic medication, statins. They inhibit the HMG CoA reductase. Major effect is decreasing the LDL and triglycerides to some extent. Side effects are hepatotoxicity and muscle toxicity. Ezetimibe decreases the intestinal cholesterol absorption. Major lipid effects are decreasing the LDL. Side effects are increasing hepatotoxicity if given with statins. Bile acid sequestration prevent the reabsorption of bile acids in the intestine and they decrease the LDL, nausea, bloating, and cramping, impaired absorption of drug and fat-soluble vitamins. Niacin. Fatty acid vitamins, fatty acid release. Okay, so niacin decreases the fatty acid release, decrease the VLDL synthesis, and decrease the HDL clearance. So they decrease the LDL and increase the HDL, flushing and pruritus, hepatotoxicity and hyperuricemia and gout. Fibrates, they activate the PPAR alpha and decrease the VLDL synthesis. They decrease the triglycerides and increase the HDL to some extent. They cause muscle toxicity and gallstones. Fish oil omega-3 fatty acids, they decrease the VLDL synthesis, decrease the apolipoprotein B synthesis. And major side effects are decreased triglycerides and increased HDL. And the worst part is the fishy taste. The Uworld point, statins stop if ALT is more than 3 times the upper limit of normal. Liver function tests are recommended before starting statin therapy. But routine monitoring is not recommended unless signs of liver dysfunction develop, like fatigue, malaise, or anorexia. Most hepatotoxicity is within 3 months. Then we have a Uworld point. The case is that patient with an angina taking the following medications: metoprolol, atorvastatin, aspirin, coming to the ER with a muscle pain, fatigue, dark urine, and acute renal failure. What medication did he take? Enzyme inhibitors that enhance the action of atorvastatin, causing these manifestations of rhabdomyolysis. Then we have an NBME point. Statins are metabolized by cytochrome P450, 3A4 except pravastatin. So statins, all of them are metabolized by the cytochrome P450, 3A4 except for the pravastatin. Another Uworld case is that history of MI with low HDL. What is the most effective therapy preventing the future CVS events? The answer is statins, not niacin. Okay, patients with decreased HDL have high risk of CVS events. Non-pharmacological measures such as exercise and weight loss and smoking cessation have significant CVS benefits. In contrast, use of medications to raise the HDL don't improve the CVS outcomes. Statins are indicated for secondary prevention in all the patients with non-CVS disease regardless of baseline lipids. The Kaplan point is that why statin cause rhabdomyolysis? Because they decrease the mevalonic acid, which decreases the farnesyl pyrophosphate, which decreases the coenzyme Q, that decreases the electron transport chain, decrease ATP, decrease sodium potassium pumps, cell swelling and rupture. Okay, decreasing the mevalonic acid will decrease the farnesyl PPI pyrophosphate, that decreases the coenzyme Q, and electron transport chain will be low. The low ATP will produce decreased amount of sodium, decreased sodium potassium pumps, cell swelling and rupture. Okay, then we have Uworld point that all statins are metabolized by P450 except pravastatin. Increased triglyceride is treated by the fibrates with niacin plus omega-3 fatty acids in the fish oil. Another Uworld point is that cholestyramine decreased the enterohepatic circulation, increased bile acid synthesis from cholesterol due to the HNG co-reductase that leads to increased cholesterol and gallbladder stones. This effect can be blocked by adding the statins to the cholestyramine, but cholestyramine decreases the absorption of statins, so administered 4 hours apart. This is an important point. The Uworld point is that anti-lipids drugs that increase the triglycerides is cholestyramine. Side effect of niacin is 5H, hot flushes. So for that we can use aspirin. Then hyperglycemia, acanthosis nigricans will be precipitated by hyperglycemia. Then hyperuricemia, that can precipitate gout, hepatitis, and harsh rash. I'm sorry, it's not. It was rash. That is pruritus. So hot flushes, hyperglycemia, hyperuricemia, hepatitis, and rash, which ends on H. So the fifth H is that. Niacin has a vasodilative effect and can potentiate the antihypertensive therapy. So we have to adjust the doses. Two combinations to avoid: statins with fibrate because they increase myopathy, cholestyramine with fibrates because they can cause gallstones. So never give statins and fibrates together. Never give cholestyramine and fibrates together. Next is hypertension with dyslipidemia. Don't use beta blockers or thiazides. They will increase the lipids. So high LDL, hypercholesterolemia, diet and exercise, still high LDL, I'm sorry, it's not HDL. If it is high LDL, hypercholesterolemia, modify the diet and exercise. If it is still high, give statins. Still high, give ezetimibe. If high triglycerides, hypertriglyceridemia, so give a diet and exercise. Still high, give fibrate, and still high, give niacin. And for the low HDL, diet and exercise is recommended. Still low, give niacin. So basically never combine fibrates with statin or cholestyramine, right? If you combine fibrates with statins, they can cause myopathy. If you combine fibrates with cholestyramine, they will cause gallstones. So the next is this thing, ezetimibe mechanism of action. This is cholesterol. Cholesterol is normally on the intestinal lumen. It is reabsorbed by the NPC1L1 receptor. So this is blocked by the ezetimibe. If it were absorbed, so cholesterol will enter the chylomicrons and then lymphatic. So basically, the first step of absorption is inhibited by the ezetimibe. Formation of cholesterol gallstones. So the cholesterol increase cholesterol excretion and cholesterol 7 alpha hydroxylase decrease the bile salt formation. Okay, so basically fibrates, gem fibrosol, they inhibit the action of cholesterol 7 alpha hydroxylase and thus decrease the bile salt formation. Bile becomes supersaturated with cholesterol and gallbladder hypomotility and mucus hypersecretion promote the stone formation. Then we can give some cardiac glycosides like digoxin, an important one. The mechanism of action is that it is a direct inhibitor of sodium potassium ATPase and indirectly inhibits sodium calcium exchanger. So increased calcium will be present in the intercellular environment that will cause positive inotropy and stimulate the vagus nerve that decreases the heart rate. So firstly, it will inhibit the sodium potassium ATPase, which means that sodium will not be able to leave the cell and potassium will not be able to enter the cell. Now it is the gradient established by the sodium potassium ATPase which help the sodium calcium exchanger to push the sodium inside for removal of calcium, right? Now when we are saying that sodium potassium ATPase itself is not working, so the gradient is not established, sodium cannot move inside to remove the calcium, so calcium will start accumulating inside and this will cause the release of calcium from sarcoplasmic reticulum as well and increased troponin C calcium binding that will lead to cardiac contractility. And other important effect is that the digoxin is vagotonic, like it stimulates the vagus and that is why it has some parasympathetic like parasympathomimetic activity, like it decreases the heart rate. Then clinical use, heart failure increases the contractility. Atrial fibrillation decreases the conduction at AV node and depression at the SA node because of its stimulation of vagus nerve. Adverse effects include cholinergic adverse effects like nausea, vomiting and diarrhea, blurry vision, think Van Gogh, okay, arrhythmias. Why should we think Van Gogh? Okay, for some reason, maybe he had blurry visions. So what does that have to do with digoxin? Okay, then AV block can lead to hyperkalemia, which indicates poor prognosis. Factors predisposing to toxicity are renal failure like decreased excretion, hypokalemia permissive for digoxin binding at potassium binding site or sodium potassium ATPase. Drugs that displace the digoxin from tissue binding sites and decrease the clearance are verapamil, amiodarone, and quinidine. Antidote of that is slowly normalize the potassium, cardiac pacer, and anti-digoxin fab fragments and magnesium. Then the next thing is symptoms of digoxin toxicity. The gastrointestinal symptoms are life-threatening arrhythmias. Okay, so basically the cardiac manifestations are life-threatening arrhythmias. The gastrointestinal manifestations include anorexia, nausea and vomiting, and abdominal pain. The neurological manifestations include fatigue, confusion, weakness, and color vision and alterations. The Uworld point is that dose of digoxin must be reduced in elderly patients even if normal creatinine, as digoxin is cleared by the kidneys and elderly exhibit age-related renal insufficiency. The initial cellular event triggering the digoxin response is to decrease the sodium influx. Digoxin toxicity delayed after repolarization by increased calcium. Ventricular tachycardia will lead to death. Digitalis is used in all supraventricular tachycardia except Wolff-Parkinson-White syndrome as it increases the conduction in accessory pathway. The best beta blocker in heart failure is carvedilol. Okay. Medications with negative inotropic agent which decrease the heart rate are beta blockers and calcium channel blockers, digoxin, amiodarone and sotalol, cholinergic agonists like pilocarpine and rivastigmine. Antiarrhythmics like sodium channel blockers, class 1. So the class 1 antiarrhythmics are sodium channel blockers. Class 1 is divided into class 1A, B and C. So as a whole, they slow or block diffuse conduction, especially in the depolarized cells. Decrease the slope of phase zero depolarization are state dependent. State dependent means that they selectively depress the tissue that is frequently depolarized, for example, tachycardia. So basically, the arrhythmogenic focus in the heart, like suppose this is the heart, so there may be some arrhythmogenic focus. Most likely, it is situated like suppose these are the pulmonary veins which are entering the left atrium. So the arrhythmogenic foci are located near the rostia, and these arrhythmogenic foci are firing at a very rapid rate, right? So they are repolarizing and depolarizing very quickly. So these antiarrhythmics class 1, they selectively block these cells. That is what we call state dependence. So class 1A, quinidine, procainamide, disopyramide. The queen proclaims disopyramide. So quinidine, procainamide and disopyramide. So okay, mechanism: increase the action potential duration. So you can see that the slope of phase 0 is delayed. Increased effective refractory period. Yeah, the effective refractory period, which was like till here, has gone all the way till here. So effective refractory period is increased. In the ventricular action potential, increase the QT interval. Some patients, some potassium channel blocking effects are also present. That is why they're causing QT prolongation, and that is why they can also predispose torsade de pointes. The clinical use both atrial and ventricular arrhythmias, especially reentrant and ectopic supraventricular tachycardia and ventricular tachycardia. Adverse effects are synchronism, headache, tinnitus with quinidine, reversible SLE-like syndrome, procainamide, heart failure, that is disopyramide, thrombocytopenia, torsade de pointes due to the increased QT interval. Class 1B, lidocaine, mexiletine, iodine Mexican tacos. Mechanism: decrease action potential duration, preferentially affect ischemia or depolarized Purkinje and ventricular tissue. Phenytoin can also fall into 1B category. Okay, so the slope is increased like here. Clinical uses acute ventricular arrhythmia, especially post-MI. Digitalis induced arrhythmia, 1B is best post-MI. Adverse effect is CNS stimulation, depression, cardiovascular depression. Class 1C, the drugs are flecainide and propafenone. Can I have price, please? Price is flecainide, P is propafenone. So what is can? Can I have price? So flecainide. Okay. Okay, so here you can see that slope is also increased, but the action potential duration is just the same. So significantly prolong the effective refractory period in the AV nodes and accessory bypass tracts. No effect on effective refractory period in the Purkinje and ventricular tissue. So this is a ventricular or myocyte action potential. There is no change in the effective refractory period. It is just the same. Minimal effect on the AP duration. The clinical use of supraventricular tachycardia is including the atrial fibrillation only as a last resort in the refractory ventricular tachycardia. Adverse effects are pro-arrhythmic, especially post-MI, contraindicated. 1C is contraindicated in structural and ischemic heart disease. So this is class 1 antiarrhythmic, will act on the phase 0. The class 3 acts on the this part 3, because class 3 is, what is class 3? They are beta blockers, not beta blockers, they are amiodarone and sotalol, and they have the potassium blocking activity and something. Class 4 acts on the, if this is pacemaker action potential, so class 4, which are the calcium channel blockers, act on the phase 0 pacemaker cells, and class 2 and 4. Okay, so class 2 and 4 acts over there. Okay, got it. Class 2 is basically beta blockers. Yeah, class 3 is amiodarone, and okay. So voltage activated sodium channel blockers. So this is activated or open sodium channel. Binds during activated and inactivated states. Inactivated close. Repolarization, that is it dissociates during the resting state, and then depolarization. So this is the QRS complex when the sodium upstroke is happening, calcium in and potassium out, and then potassium out. And we have talked about this P wave in the physiology in a huge detail. Then we have quinidine has also muscarinic receptor antagonist. Okay, muscarinic has also, the quinidine has also muscarinic receptor antagonist properties in such a way that it increases the heart rate, increases the AV conduction. So the need initial digitalization, meaning the digitalis in administration. So we need to give digitalis administration before use in the atrial fibrillation, and increase the QRS and increase the QT. Alpha blocking activity So quinidine also has alpha blocking activity, which means it causes vasodilation and reflex tachycardia. Another capital point is that procainamide is hematotoxic. Thrombocytopenia and agranulocytosis will occur. Features of drug-induced lupus erythematosus: new onset lupus symptoms, anti-nuclear antibodies and anti-histone antibodies present in more than 95% of the cases. Anti-dsDNA antibodies are rarely seen. Exposure to implicated drugs are hydralazine, procainamide, isoniazid, minocycline, and quinidine. So the Uworld point is class 1C are the slowest and class 1 agent to dissociate from the sodium channels. This results in a phenomenon known as use dependence, in which their sodium blocking effects intensify as the heart rate increases due to the less time between action potential for the medication to dissociate from the receptor. So class 1, intermediate binding to the sodium channels but also block potassium. That there is a decrease in Vmax and increase in the action potential duration. The class 2 drugs, the rate of binding and release is so rapid that there is no change in the Vmax since they block sodium window current and there is decrease in the action potential duration. So there will be no Vmax and there will be decrease in the action potential duration. Class 3, very tight binding and slow release. There will be so less Vmax and no effect on the action potential duration. Okay, I hope this makes sense. Then next Uworld point is that class 1 antiarrhythmic medication preferentially bind to and block the activated and inactivated voltage gated sodium channels in the cardiac pacemaker cells and myocytes. Dissociation of drugs from the channel occurs during the resting state, a conformational state distinct from the inactivated state that occurs following the repolarization. Class 1 antiarrhythmic exhibit use dependence, a phenomena in which tissues undergoing frequent depolarization become more susceptible to blockage. Use dependence occurs because the sodium channels in rapidly depolarizing tissues spend more time in activated and inactivated states, thus allowing more binding time for the drug. For class 1 antiarrhythmic, sodium channel binding strength is like CAB, 1C, then 1A, and 1B. Use dependence is more pronounced in the class 1C antiarrhythmics because of their slow dissociation from the sodium channel, which allows their blocking effect to accumulate over multiple cardiac cycles. This effect is enhanced with tachycardia, and resulting increase in sodium channel blockade helps to slow the conduction speed and terminate the tachyarrhythmias. The prominent use dependence affects the class 1C drugs can cause a delay in the conduction speed. This is out of proportion to the prolongation of the refractory period. This can promote arrhythmias, especially in the patient with ischemic or structural heart diseases. Then comes the class 1B antiarrhythmics. Lidocaine, mexiletine, and tocainide binds less avidly to the sodium channels than other class 1 antiarrhythmics. Dissociation from the channels occurs so rapidly that there is minimal cumulative effect over multiple cardiac cycles, resulting in little use dependence. These drugs are more selective for ischemic myocardium. Because the reduced resting membrane potential delays sodium channel transition from the inactivated to the resting state, resulting in increased drug channel binding. Class 1B antiarrhythmics are useful for treating the ischemia-induced ventricular arrhythmias, one of the most common causes of death in the short term following acute myocardial infarction. Antiarrhythmics beta blockers class 2, metoprolol, propranolol, esmolol, atenolol, timolol, and carvedilol. Mechanism is that they decrease the SA and AV nodal activity by decreasing the cyclic AMP, decrease calcium current, suppress the abnormal pacemaker by decreasing the slope of phase 4. AV node particularly sensitive, increased PR interval, esmolol is very short acting. The clinical use is supraventricular tachycardia, ventricular rate control for the atrial fibrillation and atrial flutter. Adverse effects: impotence, exacerbation of COPD and asthma. Cardiovascular effects include bradycardia, AV block, and heart failure. CNS effects of sedation, sleep alterations may mask the signs of hypoglycemia. Metoprolol can cause dyslipidemia. Propranolol can exacerbate the vasospasm in the Prince-Metal angina. Beta blockers except the non-selective alpha and beta antagonist carvedilol and labetalol cause unopposed alpha-1 agonism if given alone for pheochromocytoma or cocaine toxicity. Treat the beta blocker overdose with saline atropine glucagon. So these are class 2, decreased slope of phase 4 depolarization, prolonged depolarization at the AV node and threshold potential. Then comes the antiarrhythmic potassium channel blockers class 3, amiodarone, ibutylide, doftalide, protalol. These are aids. So mechanism is that they increase the action potential duration, increase the effective refractory period, and increase the QT prolongation. The class 3 are basically potassium channel blockers. Okay. Amiodarone, ibutylite, sotalol, although it's a beta blocker, but it has potassium channel blocking activity as well, so aids the good pneumonia. The clinical signs are atrial fibrillation, atrial flutter, ventricular tachycardia, amiodarone, and sotalol. Adverse effects: sotalol causes de pointes, excessive beta blockade, ibutylite causes torsades de pointes, and amiodarone has a lot of side effects like pulmonary fibrosis, hepatotoxicity, hypothyroidism or hyperthyroidism, because there is the 40% by weight. Amiodarone is 40% iodine by weight, so it can cause both of them. Yeah, 40% iodine by weight. It acts as heptin, so it can cause corneal deposits, blue-gray skin deposits resulting in photodermatitis. There can be neurologic effects, constipation, cardiovascular effects, bradycardia, heart block, and heart failure. Remember to check the pulmonary function test, liver function test, and thyroid function test when using amiodarone. Amiodarone is lipophilic and has class 1, 2, and 3 and 4 effects. So there is markedly prolonged repolarization. Correct. Antiarrhythmic calcium channel blockers, verapamil and diltiazem. Mechanism is that they decrease the conduction velocity, increase the effective refractory period, and increase the PR interval. Clinical use: prevention of nodal arrhythmias like supraventricular tachycardia, rate control in atrial fibrillation. Adverse effects include constipation, flushing, edema, cardiovascular effects like heart failure, AV block, and sinus nodal depression. So you can see that there is slow rise in action potential, prolonged repolarization at the AV node, and this is the threshold potential. So this is the effect of, like, repolarization phase is prolonged, and there is also slow rise in action potential because we are blocking the potassium channels. So why is there slow rise in action potential? This is understandable, but because they are so hyperpolarized that initially if normally they were starting from this point, so now they have to start from a lower resting membrane potential to move forward. But I don't know. I think that there is oh no, okay, I don't understand this one. Why is there a slow rise in action potential? It can be because sotalol has some being a beta blocker. It inhibits the calcium entry as well, so maybe that is why. Okay. I'm really sorry. I was still stuck there. Okay. So here we are talking about the type class 4. Okay. Now I'm sorry. So the class 4 is a calcium channel blocker. So definitely they will slow the action potential because this is dependent on the class. Class. This is dependent on calcium. So if they are calcium channel blockers, they are going to do that. Got it. And there is a prolonged repolarization at the AV node. Okay. Prolonged repolarization at the AV node. Why is that happening now? Now this is not clear, and this is very, very clear. So, okay, now let's move on because I don't want to confuse it any further. Drugs that prolong both the PR and QT interval are sotalol. Drugs with QRS prolongation with little effect on the QT are class 1C. Class 1C has very little effect on the QT, and it causes the QRS prolongation, by the way. The QRS prolongation means in phase 0 sodium blocking activity, that is class 1. Little effect on QT, like minimal effect on the action potential duration. Drugs that prolong the QT interval without the risk of torsade points, it is amiodarone. NBME point is that drugs that prolong the QT interval are class 1A and 3. Another NBME point is that beta blockers have no effect on the QT interval. Okay. Drugs that prolong the QT and prolong the PR interval is sotalol, so it prolongs the QT and also prolongs the PR interval. Drugs causing torsade points are verapamil, metoprolol, sotalol, lidocaine, and digoxin. Treatment of Wolff Parkinson White syndrome is amiodarone and procainamide. Class 1C exhibits strong use dependence. It prolongs the QRS at high heart rate normally. QRS decreases when the heart rate increases. Okay, so exhibits strong use dependence, that is, it prolongs the QRS at high heart rate. Normally, the QRS decreases when the heart rate increases, but with the class 1C drugs, at high heart rate, QRS prolongs. Class 3 exhibits reverse use dependence, that is, prolong the QT at slow heart rate. Okay. Drugs that decrease the heart rate may have no effect on the myocardial contractility or relaxation, that is ivabradine. Ivabradine inhibits the sodium funny channels, prolonging the phase 4 slow depolarization phase and decrease the heart rate. Ivabradine is a negative chronotropic effect with no effect on contractility or relaxation. Uses in chronic heart failure with decreased ejection fraction with persistent symptoms despite appropriate treatment. Then let's talk about okay, let's come back. Now let's talk about other antiarrhythmics. So other antiarrhythmics include adenosine. It increases the potassium efflux out of the cells, hyperpolarizing the cells and decrease calcium, decreasing the AV nodal conduction. It is a drug of choice in diagnosing and terminating certain forms of supraventricular tachycardia. Very short acting, like about 15 seconds, effect blunted by theophylline and caffeine. Both are adenosine receptor antagonists. Adverse effects include flushing, hypotension, chest pain, sense of impending doom, and bronchospasm. Magnesium, it is effective in torsade points and digoxin toxicity. Then we have antiarrhythmic drugs like, according to the Vaughan-Williams classification. So there are like class 1A, class 1B, and class 1C, and class 2, 3, 4 drugs. So class 1A, sodium channel blockers, they include disopyramide, procainamide, and quinidine. The predominant effect is that slow the action potential conduction velocity and prolong the action potential duration. Class 1B, lidocaine, mexiletine, and phenytoin. There is no effect on action potential conduction velocity and shortens the action potential duration. Class 1C, flecainide and propafenone, slows the action potential conduction velocity and minimal effect on the action potential duration. Class 2, beta blockers, so atenolol, metoprolol, esmolol, and carvedilol, slows the sinus node discharge rate, slows the AV nodal conduction, and prolongs the effectiveness. Class 3, potassium channel blockers, imiodarone, dronidarone, doctylite, sotalol. Class 2, no effect on action potential conduction velocity and prolongs the action potential duration. Class 4, non-dihydropyridine calcium channel blockers, verapamil and diltiazem, slows the sinus node discharge rate and slows the AV nodal conduction and prolongs the refractoriness. Class 1, sodium channel blocking antiarrhythmics. Class 1A, quinidine, procainamide, and disopyramide. Inhibition of phase 0 depolarization is intermediate and effect on the length of action potential is prolonged. Class 1B, lidocaine and mexiletine. Inhibition of phase 4, phase 0 depolarization is weak and effect on the length of action potential is shortened. Class 1C, flecainide and propafenone. Inhibition of phase 0 depolarization is strong and effect on the length of action potential will have no change. So number of sodium channels blocked, weakest binding and faster dissociation is for the class 1B, lidocaine and mexiletine. Strongest binding and slower dissociation for class 1C, so it is CAB, like CAB. Flecainide and propafenone, class 1A, that is quinidine, procainamide, and disopyramide, they have an intermediate binding and dissociation. Medications that can cause hyperkalemia. The first ones are non-selective beta blockers. Okay, so non-selective beta blockers interfere with the beta 2 mediated intracellular potassium uptake. Angiotensin converting enzymase inhibitors, inhibition of angiotensin 2 formation with subsequent decrease in the aldosterone secretion. Angiotensin 2 receptor blockers, they block the angiotensin 1 receptor, thus decreasing the aldosterone secretion. Potassium sparing diuretics block the epithelial sodium channels, that is ENaC or aldosterone receptor. Cardiac glycosides, for example digoxin, inhibition of sodium potassium ATPase pump. And NSAIDs, they impaired local prostaglandin synthesis, reduce the renin and aldosterone secretion. Next is medications with negative chronotropic effects. So beta adrenergic blockers, for example metoprolol and atenolol. Non-dihydropyridine calcium channel blockers like verapamil and diltiazem. The cardiac glycosides like digoxin, amiodarone and sotalol, and cholinergic agonists like pilocarpine and tivastigmine. Major side effects of amiodarone are the cardiac side effects include sinus bradycardia and heart block, proarrhythmia and QT prolongation, pulmonary chronic interstitial pneumonitis. Endocrine effects are hypothyroidism and hyperthyroidism. Gastrointestinal and hepatic manifestations include elevated transaminases and hepatitis. The ocular manifestations are corneal microdeposits and optic neuropathy. The dermatologic manifestations include blue-grade skin discoloration, and neurologic manifestations include peripheral neuropathy. Ivabradine mechanism, selective inhibition of funny sodium channels, prolonging the slow depolarization phase, that is phase 4, decrease SA nodal firing, negative chronotropic effect without inotropy, and reduce the cardiac oxygen requirement. The clinical use is chronic stable angina in the patients who cannot take beta blockers, chronic heart failure, and reduced ejection fraction. The adverse effects are luminous phenomena, visual brightness, hypertension, and bradycardia. So here you can see that ivabradine, it is inhibiting the funny channels, like this. So ivermectin lengthens the slow diastolic depolarization phase. So okay, we are going to complete this in this session. It will be a bit long, right? Because we are just 5 pages to go, and then this CVS will be completed. So the cardiovascular effects of the adrenergic drugs are for the alpha 1 agonists, like midodrine or phenylephrine. The heart rate will be decreased in the reflex action because the main action of alpha 1 agonist is on the blood vessel. They cause vasoconstriction. That vasoconstriction will increase the blood pressure, and as a reflex action, the heart rate will decrease. The cardiac contractility will decrease as the reflex action, and systemic vascular resistance will increase. Alpha 1 antagonist. The examples are doxazosin and terazosin. So they cause vasodilation. So as that vasodilation will lead to bradycardia, and no, that vasodilation will lead to hypotension, and that will lead to a reflex tachycardia, that is increase in the heart rate. There is no effect on cardiac contractility, and systemic vascular resistance decreases. For alpha 2 agonists like clonidine, heart rate decreases by central receptors. Decrease central. Okay, so the vascular systemic vascular resistance also decreases by central receptors. The beta agonists like isoproterenol, heart rate increases, the cardiac contractility increases, and the vascular resistance decreases by beta 2 agonist effect. Then beta 1 agonist metoprolol and atenolol, the heart rate decreases, cardiac contractility decreases, but the vascular resistance is not affected by the beta 1 agonists. Now we are done with the CVS, and there are some additional points. These are like 2021 updates. Right now we are sitting in 2024. So, but although I will always recommend you to read the latest edition of First Aid whenever you are preparing for your step exams or any other exams. But the basic core concept is the same, right? And this book is like very elaborate and up to date. Even now, even today, I will really say that even today it is up to date. There are very few points which are added in 2023 and 2024 First Aid. I have seen that. So like you can listen to these sessions and then you can go for the additional points. But I think that this book is really has covered a lot of topics in a very profound manner. So subclavian steal syndrome, stenosis of subclavian artery proximal to the origin of vertebral artery. I hope you remember that we read coronary steal syndrome a few pages back, but now it is subclavian steal. It is very important. So stenosis of subclavian artery proximal to the origin of vertebral artery leads to hypoperfusion distal to the stenosis. This will cause, it is like this. This will cause a reversed blood flow in the ipsilateral vertebral artery, reduce cerebral perfusion. Okay. On exertion of the affected arm, causes arm ischemia, pain, paresthesia, vertebrobasilar insufficiency, dizziness, vertigo, more than 15 millimeters of mercury difference in the systolic blood pressure between the arms, and associated with arteriosclerosis, Takayasu arteritis, and heart surgery. So here you can see that suppose this is the point of obstruction, the vertebral arteries. What is that? This is left vertebral artery. So they're saying that if there is a occlusion proximal to the origin of vertebral artery, like suppose if I have to zoom it in. Now here you can see that this is the yeah. So now here you can see that this is the subclavian artery, and subclavian artery is giving rise to, this is subclavian artery giving rise to vertebral artery on the right side, and this is giving rise to vertebral artery on the left side. Now you can see that this is the stenosis proximal to the origin of vertebral artery. The blood was supposed to flow in this direction, but it can't because of the stenosis. So the arm that is distal to this stenosis, because subclavian artery supplies the arm, so that undergoes ischemia. To avoid that, the blood flow from the right vertebral artery, instead of moving upwards into the circle of Willis, starts moving downwards into the left vertebral artery, and then it comes back into the arm. So it goes upwards, but the amount that was supposed to reach there is not reaching, and it's shunting backwards. So this is subclavian steal syndrome, and this can present with vertigo, dizziness, along with arm ischemia, and what? There will be ipsilateral vertebral artery, reduced cerebral perfusion of the on exertion. Like on exertion, the arm will not even receive ample amount of blood. So it is associated with the arteriosclerosis and Takayasu arteritis, the one pulseless vasculitis, and heart surgery. Okay, chronic ischemic heart disease. Myocardial hypertension, potentially reversible left ventricular systolic dysfunction in the setting of chronic ischemia. Contrast with myocardial stunning, a transient left ventricular systolic dysfunction after a brief episode of acute ischemia. Paroxysmal supraventricular tachycardia, a narrow QRS complex tachycardia. Important that in supraventricular tachycardia, the QRS complexes are narrow. Most often, due to arterioventricular nodal reentrant tachycardia, commonly present with sudden onset palpitations, diaphoresis, lightheadedness. Treatment is to terminate the re-entry by slowing the AV nodal conduction, for example, the vagal maneuvers and IV adenosine. Electrical cardioversion if hemodynamically unstable. Definitive treatment is catheter ablation of re-entry tract. Then we have hereditary channelopathies, inherited mutation of the cardiac ion channels, abnormal myocardial action potential, with risk of ventricular tachyarrhythmias and sudden cardiac death. Antiarrhythmics, sodium channel blockers, slow or block the conduction, especially in the depolarized cells, slope of phase zero depolarization, positive action at faster heart rate, state dependent increase in heart rate, uh, shorter diastole, sodium channels spend less time in the resting state, drugs dissociate during this state, less time of drug to dissociate from the receptor. In fact, most pronounced in this like 1C, 1A and 1B due to the relative binding strength and fast taxi cap. Okay. Lipid-lowering drugs include PCSK9 inhibitors like alirocumab and evolocumab. They decrease the LDL too much, then they slightly increase the HDL. It is on the table like listed before, and it slightly decreases the triglycerides. Inactivation of LDL receptor degradation and increased removal of LDL from the bloodstream. Myalgias, delirium, dementia, and other neurocognitive effects are the side effects. Fish oil, marine, omega-3 fatty acids. So they increase the triglycerides slightly. Okay. Slightly increase the HDL as well, and slightly decreases the triglycerides at high doses. It is believed to decrease the free fatty acid delivery to the liver and decrease the activity of triglyceride synthesizing enzymes. Nausea and fish-like taste as the side effects. Then we have cardiology Uworld updates. Embryological abnormalities. Failure of apoptosis can present with syndactyly. Failure of fusion can cause hypospadias. So an example of failure of fusion is hypospadias, and failure of obliteration, brachial cleft cyst. How you can diagnose paradoxical cryptogenic stroke? It can be evaluated by use of echo with bubble study. Agitated saline plus air is injected through the veins. Normally, you should see the air bubbles in the right heart. If the bubbles appear in the left side, it is a positive bubble test, and it is moving from the patent foramen ovale, or atrial septal defect to the right side and to the left side. To the left side. Yes, yes. So yeah, that is how we diagnose the paradoxical stroke. Positive test existing shunt between. So positive test is existing shunt between the right and left heart, mostly patent foramen ovale and less commonly atrial septal defect. Local factors influencing the coronary blood flow are adenosine, prostaglandin, serotonin, autonomic nervous system, and neurotransmitters. Bradykinin, mechanical shear stress, thrombin, nitric oxide, endothelium, and derived relaxation factors. Site of ablation in the atrial flutter, the isthmus between inferior vena cava and tricuspid annulus. To access the left side of the heart, there are two approaches. The femoral or radial arteries, then we move to aorta, then to the left side of the heart, or from the femoral vein to the inferior vena cava to the right atrium, then puncture the interatrial septum at the fossa ovalis to reach the atrium, left atrium. Puncture is small and that heals spontaneously. So these two approaches can be used. Coronary grafts. Occlusion of left anterior descending artery, with the best graft is left internal mammary artery. Superior patency rate. So internal mammary artery is better because it has a superior patency rate. Multiple occlusions on or non left anterior descending artery with GSV. What is that? Is usually used. What is that? Great septus vein. Okay. So if there are multiple occlusions, so we can use greater septus vein. If only lead is occluded, we prefer internal mammary artery. Anatomy of great septus vein is 3 to 4 centimeter inferior lateral to the pubic tubercle. Access is done from the medial leg or at the femoral triangle. Deep circumflex iliac vessels parallel and superior to the inguinal ligament. Causes of coronary sinus dilation seen on echo. Pulmonary hypertension, TAP, VD. Where does it? I think it is R. Total annulus pulmonary venous return, but it is just saying D, so maybe drainage. Persistent left superior vena cava drain into coronary sinus. Okay. persistent left superior vena cava. So normally the left superior vena cava is obliterated, but if it persists, so it is turning into coronary sinus that is going to cause coronary sinus dilation. Otherwise, it is an indicative of pulmonary hypertension. Treatment of post-infarction pericarditis. It is usually treated by aspirin. Acetaminophen is effective antipyretic and analgesic, but not anti-inflammatory. So post-infection pericarditis is treated with aspirin with colchicine. Okay. Mechanism of fish oil omega-3 fatty acid decreases the VLDL and apolipoprotein B synthesis. Treats triglycerides, HDL, and its side effects are fishy taste. Then we have these two pages. Okay, so this is a table about something. Yeah, so cardiovascular effects of we have talked about that. We have discussed this table, like the whole of it. So we are not talking about it again. 4 phases of Valsalva. The first phase, phase one, onset of straining with increased intrathoracic pressure. Heart rate doesn't change, but the blood pressure rises. In phase 2, decreased venous return and consequent reduction in the stroke volume and pulse pressure as straining continues, heart rate increases and blood pressure drops. So in phase 1, heart rate does not change, but the blood pressure rises. But in phase 2, heart rate increases and blood pressure drops. In phase 3, release of straining decreases intrathoracic pressure and normalizes pulmonary blood flow. In phase 4, blood pressure overshoots in normal heart with return of heart rate to the baseline. Digeorge syndrome associated with the interrupted aortic arch, complete atresia. Ventricular septal defect murmur is usually cannot be heard at birth, audible around 4 to 10 days after birth as pulmonary venous return decreases. So, yes, left to right shunt, the RVSD may not be associated with the murmur. Types of xanthomas. Eruptive xanthomas, yellowish papules where triglycerides or cholesterol are raised. Tuberous or tendinous, Achilles tendon and extensor finger tendons. Plain xanthomas, linear lesions in the skin folds associated with the primary biliary cirrhosis. Xanthelasma, periorbital plaque, 50% with a normal cholesterol level. Vasospastic angina occurs at rest, nighttime, triggered by amphetamines. Ergotamines act as vasoconstricting due to its action on alpha receptor, partial agonist, and serotonin receptors. Collagen in different stages of myocardial infarction. Type 3 collagen, seen after 7 days after MI but eventually replaced by type 1. And type 1 collagen most abundant in mature scar tissue. What are the thyroid complications of amiodarone? Thyroid complication is more common with pre-existing thyroid tissue, so TSH should be assessed to diagnose any subclinical affection. Hypothyroidism decreases the production of thyroid hormone. Okay, then cystic medial degeneration characterized by the myxomatous degeneration of the media with pooling of proteoglycans in the middle layer, like we're talking about the aneurysm formation. So in that, it's also a complication of atherosclerosis. So cystic medial degeneration, it is characterized by the fragmentation of elastic tissue, Bassett weave pattern, Bassett or basket. I think it is basket weave pattern, but okay. These fragments make cleft-like spaces in the media filled with extracellular matrix, ECM matrix. It is caused by Marfan syndrome as it affects the fibrillin 1, which is major ECM component. These changes can be made by beta amino propionitrile, which inhibits lysyl oxidase that decreases the cross-linking elastin and collagen fibers. Subacute bacterial endocarditis caused by the enterococcus, GI and GU surgery, staph eridens, oral dental surgery, and low virulence, and staph epidermidis, prostatic valve, staph ovis, gallbladder ulcerative colitis, or colorectal cancer. Non-bacterial thrombotic endocarditis, meningitic endocarditis. Causes include advanced malignancy, may be associated with the APL. What is APL? APL is antiphospholipid syndrome, SLE, DAC, pathogenesis of non-bacterial thrombotic endocarditis, cytokines produced lead to endothelial injury, platelet aggregation with fibrin and ICs. What is IC? Okay, I have to think it through. What is IC? Then white thrombus and more liable to embolization than EC. What enough? Okay, why do they do it? What is IC and what is EC? Platelet aggregation with fibrin and ICs Okay, forget about it. Okay, just tell me in the comment section. I don't know what IC and EC means. What is Duke's criteria? So for the Duke's criteria, blood culture obtain three separated in time and location, multiple positive cultures of the same organism, strong evidence of endocarditis. Echocardiography, look for vegetations not ruled out by negative echo. And chest X-ray may reveal septic emboli in the right-sided endocarditis. Acute rejection of cardiac transplant. Incidence of acute rejection of cardiac transplant is 40%, mainly due to cell-mediated immunity. Host T lymphocytes sensitization against the graft MHC antigens, rarely due to anti-donor host antibodies, diagnosed by direct immunofluorescence. Symptoms of heart failure in 1 to 4 weeks after transplantation indicate heart rejection. Histological appearance is dense infiltrate of mononuclear cells of the T lymphocytes. Small vessel vasculitides with the immune complexes, cryoglobulinemia, vasculitis affecting the skin, GI, and renal system, no joint involvement, contrasts noxaline purpura, which has joint involvement, caused by antibodies that condense at decreased temperature, IgA deposit with the cryoglobulins, adults associated with hepatitis C and type 1, membranoproliferative glomerulonephritis, present with Raynaud phenomena, palpable purpura, rickettsia, NCA positive vasculitis, vasculitis affecting the skin caused by the immune reaction to the rickettsiae, present with Rocky Mountain spot fever, pterygia on extremity that spreads to the trunk, and inoxaline purpura. Now there are certain drugs, ACE inhibitors increase the renin level, angiotensin level is also, and 81 angiotensin 1 is increased while angiotensin 2 is decreased because this cannot be converted into this. Aldosterone will be decreased and bradykinins will be increased because bradykinins are broken down by the ACE inhibitors, so they will be increased. Angiotensin receptor blocker renin will be increased, angiotensin 1 will be increased, angiotensin 2 will be increased, aldosterone will be decreased, and bradykinins will have no change. So that was all about the CVS. Until next time, Allah Hafiz, fi amanillah, and take care.